Hopefully you know me. My name is Adam Bregman, one of the third-year medicine residents. I'll be going into nephrology at the University of Colorado in Denver this upcoming fall. So when I started thinking about my senior talk, it was probably about a year ago, and the question was, well, do I do it about kidneys? Because that's kind of what everyone was expecting. But I decided to stray a little bit from that and do something maybe even a little bit closer to me. So my family is just composed of doctors. We have about 15 doctors in my immediate and extended family. And my Uncle David was an extraordinary man. He died in 2012, but I want to tell you a little bit about his legacy because we see it every day. So what is the intra-aortic balloon pump? And this is kind of where I'm going to start. So the history is this guy, Dwight Harkin, this was at Cleveland Clinic in 1958. He brought up the idea of counterpulsation to augment diastolic blood pressure, to increase coronary blood flow, and thus cardiac output, because the filling of the coronaries happens during diastole. The major work on this happened also in Cleveland Clinic in 1961. The previous experiment was done in dogs in which their femoral arteries were cannulized and blood flow was given during diastole, but they hemolyzed. So that was obviously detrimental to the dogs and they died. But he did speak about that in a conference. This was the first time that a balloon was actually used. This time it was with carbon dioxide. Now we use helium, and I'll get to that a little bit later. But what he did was he used dead dogs and then anesthetized dogs, and he showed that blood flow in the brachiocephalic artery and the femoral arteries increased, and that end diastolic pressure, which is effectively your afterload, decreased when you gave them this diastolic augmentation. Then they used human cadavers with dye to show that coronary perfusion increased during diastole in a retrograde fashion. If you look up the word intra-aortic balloon pump, you're going to see Adrian Kantrowitz's name. He is the godfather of IABP, and I would say that David Bregman, my uncle, is like the little boy. So Kantrowitz, what he did was he was actually the first one to use this in a human being in 1967. Obviously, he had to try this in cadavers and dogs first. But what he did was he built a machine that would time the diastolic augmentation, that filling of the balloon during diastole and the deflation of the balloon during systole. He timed it to both the ECG as well as the cardiac cycle, the aortic pressure. And I'll show you a diagram of that soon. But in the ECG, you want it to deploy obviously after the QRS complex, pretty much in the middle of the T wave, which is where diastole is, and to deflate right before the QRS complex. Or if you're looking at the arterial waveform, right at the dicrotic notch, which is effectively the beginning of diastole, the end of systole, where your aortic valve closed. So I want to show you what this is. So you see that they can either A, cannulate the carotid, bad idea, or they can cannulate the femoral artery. And I'll show you kind of how barbaric it was when they first started it and how they used 30 French Dacron grafts initially, and then how we ended up with a 12 French Seldinger technique. But they fed this up just past the subclavian, the left subclavian, hooked up an ECG, and then monitored CBP as well. This is just a gross diagram from his initial paper. That you can see the pump is on, meaning the balloon is going up during diastole, and you can see that the mean arterial pressure increases. Keep in mind that this is mostly driven by diastolic pressure, because your diastolic pressure on pump will be higher than systolic. Your urine increases, and your venous sat increases while your CVP drops. So just a little bit of physiology, because what would any lecture about cardiology be without physiology? So let's take this first. So this is kind of what you would see on the machine on pump nowadays. But this is your unassisted systole. This is normal. So you have isovolumetric contraction, ejection, and this is your systolic pressure of 120, your dicrotic notch, beginning of diastole. This is your unassisted aortic and diastolic pressure. This is your elastic recoil of your aorta, keeping your diastolic pressure, and it is unassisted. So what you can see is now the balloon goes up. This is a 1 to 2. You have an unassisted systole, meaning the balloon has not created this pressure sink yet in the aorta when it deflates. So it inflates during diastole, and you can see now the pressure is higher in diastole than it was in systole. Blood flow will go retrograde back to the coronary arteries and improve myocardial oxygenation. And then here you have your assisted aortic and diastolic pressure, and it is lower. You can see this, it is lower than the unassisted. So this allows you to have less afterload, decreasing myocardial work. And then your assisted systole is afterwards, once you now have full deflation, and you can actually see that it's lower. It's lower than the unassisted systole. And that's something that you'll typically see. It's either at the same level or below what it was unassisted. And this is kind of the same diagram as to when the balloon is inflated, but it shows you your tension time index. So this means your wall tension and the amount of time that your wall is contracting, as well as showing your myocardial work and how it is decreased, and your diastolic filling time and oxygenation is increased. This is just a cool diagram of exactly what I was showing. And then this is what you would see. This is actually, this is 1-to-1. So meaning for every QRS, you have a diastolic inflation and a systolic deflation. So where does it sit? I kind of alluded to this before. It sits just distal to the left subclavian. It blows up during diastole, and it deflates during systole to provide this pressure sink, decreased afterload. And this kind of just further elaborates on what I said. You're decreasing everything that will cause your myocardium to work. So you're just decreasing the amount of work and increasing the supply of blood and decreasing demand. Now I want to talk about David Bregman as a man. He's certainly a Bregman, and maybe you can see some of his resemblance. He was a portly fellow, and no one will doubt that. This is my Uncle David, probably at age about 50. This is my grandfather Leon, his father. This is David, and this is my father back when he had a lot more hair. And then this is this character is me, and this is my cousin Jamie, his daughter. I kind of want to just tell you one thing about my family. So if you've ever read the book Outliers by Malcolm Gladwell, I think we are that family. We came to America in the early 1900s as an immigrant family from Russia and Austria, and the parents were a rabbi and a dressmaker. And what did my grandfather Leon do? He was a dressmaker. And what did all his kids do? Because of that work ethic, they all became doctors. 3 doctors and a social worker. So I'll get to what he did in a minute, but he was a pretty well-traveled man, and he was asked by many countries, all pretty much all communist, to come to their country and to teach them his techniques of cardiac surgery, including the use of the intra-aortic balloon pump in cardiac surgery, which which he pioneered in 1968. So this is when he went to China. He was there for a month, and he performed 39 open heart surgeries in a month. And he taught them how to use the intra-aortic balloon pump, and he also wrote a paper after this, an opinion paper, on the state of cardiac surgery in China. That's a really interesting read. So I want to play a game called Name That Famous Surgeon. So it's this guy, and I'll show you a better picture of him in a minute. No, it's not DeBakey. This is my Uncle David. I'll give you a hint. This is his name right here, Denton Cooley. And keep in mind, this was in 1977. This was before his name was really well known in the intra-aortic balloon pump community, because in 1979, he was the one that changed the balloon pump from being a surgically inserted and surgically removed apparatus to an apparatus that could be performed at the bedside with the Seldinger technique. Okay, this is a better picture. So this is David, this is Denton Cooley, and who's this man? That's DeBakey, that's right. I found this picture interesting after I read a little bit more about these guys. So it turns out that Denton Cooley created the Texas Heart Institute, and Denton Cooley actually performed the first pediatric heart transplant. DeBakey was supposed to actually do that surgery, and he was out of town or something, and they got into a fight in 1970 and didn't kind of become friends again until just shortly before DeBakey's death, 40 years later. So this was kind of when they were fighting. This was in 1974 at a conference, and this is DeBakey again. One thing that I want to point out about David, so he was born in Brooklyn in 1942, graduated Lincoln High School in 1960. He graduated summa cum laude with a math major from NYU Uptown in 64. He then went to SUNY Downstate, where two other members of my family went to medical school. That's in Brooklyn, and it was affiliated with Kings County as well as Maimonides, which is really important because kind of everything in this lecture that I'm talking about is everything is star-crossed, everything is meant to be. So David wrote his first paper about the intra-aortic balloon pump in 1970. So if you're doing the math, he was a second-year resident when he wrote this. I haven't done anything, and this guy was writing about balloon pumps. So how did he get involved in it so quickly? Well, it turns out that at SUNY Downstate, they were doing work on this in dollars, so he joined that. And where was Kantrowitz? Kantrowitz was also affiliated with SUNY Downstate at Maimonides. And in 1967, when a 45-year-old woman came in cardiogenic shock after a posterior-inferior MI, that's when he inserted the first balloon pump. 1967 at the hospital that he was rotating, which obviously started his interest. And he went on to do his cardiothoracic surgery fellowship at Columbia University. He had 35 publications, and I told you his first one was in 1970. He practiced at Columbia University until 1983, at which point he took over as chief of St. Joseph's Hospital in Paterson, New Jersey. So these are just a smattering of some of his articles. So intra-aortic balloon in open heart surgery. I'm going to show you his book that he published some of his original research in, and also talked about this newfangled device that you may have heard of, the LVAD. So this is amazing. So he was a chief resident when he wrote an opinion paper that was published in New England Journal to people that used the intra-aortic balloon device. Because no one before him had used it in cardiac surgery. It was used in cardiogenic shock. That's when Kantrowitz used it. His case series was in patients with cardiogenic shock. Uncle David said, let's try to use it in cardiothoracic surgery patients, either before revascularization to try to reduce the spread of the penumbra and reduce ischemia, to try to wean them off bypass. And I'll show you that. And then this is just a kind of interesting story, again, how everything is star-crossed. This guy, Hussein Baluchi. So when I was a second-year medical student at University of Miami, we had a lecture about who Hussein Baluchi was, because he was at University of Miami, and he jumped on David's research and did